I invite Dr. Mahesh, who's heading neuro-ophthalmology at Aravind, to speak to us as how electrophysiology is our friend. And in fact, in a lot of these situations, particularly where we tend to get a normal-looking fundus, I didn't purposefully cover it there in those cases. Electrophysiology really helps us, pick up the lesions. So over to you, Dr. Mahesh.
At the outset, good morning. At the outset, I would like to thank Dr. Digvijay Singh for having included me in this instruction course. So the topic is electrophysiology, and what is electrophysiology is a non-invasive test, a functional indication related to the different location cell types within the visual system. So these are all the various electrophysiological tests which which is self-explanatory. You can see this EOG, full field ERG at these levels. And what we will be interesting as a neuro-ophthalmological course is we will be interested mainly in the visual evoked potential as well as the pattern ERG, and these two are more relevant in the neuro-ophthalmological perspective. So I will be speaking only on these two things. Of course, the multifocal ERG is focused on all these points. So a VEP is defined as a function of the entire visual pathway from the retina to the area of the visual cortex, and primarily reflects the central retinal projection to the occipital lobes. In a nutshell, we can say that VEP is a localized form of an electroencephalogram of the occipital lobe. So that is what a VEP is. These are all the various electrodes which are placed. And differentiating VEP from a MRI is, VEP is more of a functional assessment, whereas MRI is more of an anatomical assessment. VEP gives a physiology of the anatomical pathway, and whereas MRI gives an accurate information of the structural defect. VEP lateralizes the lesion but doesn't localize it into a particular point, whereas a neuroimaging localizes it to a particular point. However, the VEP is useful grossly in assessing the optic nerve function to be affected in the prechiasmatic or in the anterior portion of the optic nerve. Indications for a visual evoked potential. It is indicated for functional defects in the upfront visual pathway. In infants, non-verbal infants, patients with intellectual disability, and aphasic patients. Malingering patients, when the symptoms do not correlate with the signs, we can employ the VEP. Opaque media, unexplained vision loss, where we don't know whether it is an optic nerve or a macular problem, we can employ the VEP. Not only that, we can also do it for prognostication purposes, as we will be seeing in subsequently in cases of optic neuritis and multiple sclerosis in the opposite eye. So all these VEP standards are created by the International Society of Clinical Electrophysiology of Vision Guidelines, ISEF, which is as it is called as, and these are all the gross parameters which are assessed. Ideally, we look at the latency and the amplitudes of the P100 wave. So latency is the implicit time which where there is a peak of the P100 wave, and the amplitude is the distance between the peak and the trough of the P100 wave. There are three different modalities of testing this. A gross flash VEP, where there is just an on and off pattern such as this one. So this is done when the visual acuity is extremely low and we just need to know the integrity of the visual pathway. So there is the other pattern, on and off pattern, where there is a we just switch on the pattern and switch it off. This is used occasionally in cases where the media is hazy, but the most common pattern which is used, the pattern reversal, which alternates between this checkerboard and the other checkerboard between black and white, and this is most commonly used. So how do we interpret the pattern VEP which is commonly used? We look at the amplitude loss. If the amplitude is lost, it indicates an axonal loss, which means the nerve has been destroyed. So this ideally occurs in a ischemic optic neuropathy or toxic optic neuropathy sometimes, where there is a destruction of the axons. Other thing we look for is a peak delay, as we saw the implicit time. Peak delay means usually it indicates a demyelination because there is a conduction delay. We all know that conduction is done by the myelin sheaths, and whenever there is a demyelination, there is a conduction delay, and it classically occurs in demyelinating optic neuritis and sometimes in aging conditions. Sometimes both the amplitude and the implicit time is affected, and these can occur in nerve compression such as compressive optic neuropathy like tumors. What tumors does is actually destroys the nerves as well as delays the conduction also. So in the initial phases of the tumor there is just a latency delay, and if we can catch that and we can operate the tumor, for example a pituitary tumor, we have seen cases where it can recover completely to 6/6 without any residual visual field loss. But however, if the tumor is prolonged, it can lead to axonal loss and amplitude problem also. So now what is this pattern ERG? Pattern ERG is derived from the macular retinal ganglion cells as well as the rest of the retinal ganglion cells. So why VEP alone is not enough to detect a neurological dysfunction? Because VEP is predominantly from the occipital lobe, and majority of the occipital lobe is from the macular area. If we know that 60% of the occipital lobe is subserving the macular function, so isolated based on the VEP alone we will not be able to detect whether it is a optic nerve function or a macular dysfunction when there are no other associated signs like an relative afferent pupillary defect, etc. So we always have to complement the VEP with the pattern ERG, and we should know that it is derived from the macula and the retinal ganglion cells. So it gives a meaningful evaluation for the VEP to exclude a macular cause of the VEP function. So how do we interpret this PERG? There are two peaks, P50 and N95. P50 is derived predominantly from the macula, and N95 also has macula and the retinal ganglion cells, and N95 is exclusively from the rest of the retinal ganglion cells. So selective P50 reduction or delay can characterize macular dysfunction, and selective reduction in N95 with a normal P50 suggests dysfunction at the retinal ganglion cells. So we see some examples quickly. A compressive optic neuropathy, as we have seen, both delays both the peak as well as the N95 P50 ratio in a pattern ERG, and there is a delay in the P100. There is a delay in the latency of the P100th wave in compressive optic neuropathies. In ischemic optic neuropathy, because there is an axonal destruction, there is a some degree of mild degree of latency delay, but predominantly it's an amplitude reduction in ischemic optic neuropathy. In optic neuritis, the latency is delayed, prolonged, and anything more than 8 microseconds between both the eyes is considered significant, and anything more than 115 milliseconds also is considered significant. Toxic optic neuropathy again can cause an amplitude loss as well as the latency delay. Amplitude is grossly reduced. With indirect traumatic optic neuropathy, again there is a delay in the latency as well as there is a destruction of the nerves. So amplitude also is reduced. We can use prognostication. If this ratio of P100 amplitude between the normal and the unaffected eye is 0.67, which is more than 50% of the unaffected amplitude, in general the prognosis is relatively good. However, if the ratio is predominantly reduced, then the prognosis is not so good, as in this case it's only 0.22. So this was a study in our hospital of 41 patients, and the P100 latency was significantly affected even after 1 month in all these traumatic optic neuropathy patients. So in summary, in a suspected or visual pathway dysfunction, perform a PERG. If P50 is normal and this ratio is normal, PVEP alone is abnormal. Pattern VEP indicates a pure optic nerve dysfunction. If P50 is normal and this N95 P50 ratio is abnormal, meaning it's a retinal ganglion cell dysfunction, and pattern VEP also is abnormal, it means that optic nerve dysfunction plus retinal ganglion cell dysfunction. However, if this PVEP is normal, then we may conclude it's a retinal ganglion cell dysfunction. Thank you very much for your attention.
Thank you, Dr. Mahesh, and just stay on the dais, and if I can now invite all the co-instructors to come up. We're now going to have the neuro-ophthal rapid fire cases, and we'll get pearls from all of them. Dr. Swati was to cover neuroradiology, but she unfortunately couldn't be here today. Yeah, but we'll have a short discussion on neuroradiology as well there. So, any questions?
Electrophysiology in traumatic optic neuropathy. ERG.
Or any other test.
VEP.
VEP will be
So early VEP, neuropathy VEP. If you're thinking maculopathy, if you think commercial retina, then ERG. But of course, I think they would complement each other. So you may require an ERG and a VEP if you want more. So if they may be simultaneously injury to both the macula and the optic nerve because of the injury. So if when in doubt there, or you have a vitreous hemorrhage and you don't know, the vision loss is very, very poor, is there a traumatic optic neuropathy? Of course, the pupil will help. But yeah, electrophysiology, VER, there, flash VER, increase in the latency, decreased amplitude would help. And of course, ERG would really not tell you there anything.
So, and just one caveat that whenever, obviously in the modern day, you're going to advise electrophysiology only when you have a doubt, when it's not very clear. So it always is useful to advise both ERG and VEP, because please remember, even if there is an extensive photoreceptor damage, your VEP will be abnormal. That does not mean, as what he suggested, that does not mean that patient has an optic nerve problem. Because if the conduction is not happening right from the retina side, VEP will still be abnormal. So it always helps to have both together.